Welcome to another exciting Advances in Surgery channel program. Delighted today that I'm sure again we have at least 100 countries represented and probably tens of thousands of people from around the world hearing this fabulous session that was created by my colleague at Cleveland Clinic main campus, professor of surgery at the Cleveland Clinic Case Lerner College of Medicine, Dr. Mike Rosen. He in turn has pulled on the expertise of his many colleagues in the world of hernia surgery to put together this absolutely spectacular program today. And I'm going to turn over to Dr. Rosen to describe today's program and introduce our faculty.
Well, first of all, I want to thank Steve and AIS for asking me to put this together, and for a wonderful faculty who I think, as you will all see from these lectures, have really done a spectacular job. And this session is particularly, I think a lot of times in hernia surgery, we like to focus on a lot of the esoteric, more complex operations. But really what I tried to put together today and what I think our speakers really accomplished was how to tackle some of the routine, everyday bread and butter hernia cases that we see, and try and not create some of those disasters that require much more advanced techniques to take care of. So with that, I look forward to a great panel discussion. And thank you all the speakers, and again, thanks to Steve and AIS for putting this together.
Thanks again, Mike. Looking forward to outstanding lectures, to wonderful interactive panel discussion. And I encourage our audience from around the world, please use the chat function because we prefer that you be active rather than passive participants. And throughout the course of the lectures and the discussion, you can interact with our faculty. Not all of them can always be present for the entire show, but they certainly endeavor to be able to engage with you in conversation. So thanks to the AS channel, thanks to our sponsors of today's program, and thanks to you, our audience.
Okay, hello everyone. I'm Clayton Petro, and I'm a surgeon at the Cleveland Clinic who specializes in abdominal wall reconstruction. And I'd like to thank the AIS for inviting me to take part in this series of talks. Preoperative optimization is a broad topic that I could probably dedicate an hour to, but I hope at least in the next 10 to 12 minutes I can convey our philosophy on these topics at the Cleveland Clinic and some of the data that drives our decision making. I do not have any financial disclosures. I do have these 3 grants for projects that I'm running. So the idea of patient optimization is to give the most complex patients the best chance of getting through their reconstruction with a durable mesh repair. And it's also to keep straightforward patients from becoming these complex disasters. I think anyone who does abdominal wall reconstruction at a high volume starts to respect the degree of wound morbidity that comes along with these operations, particularly when it comes to things that we care about most, which are surgical site infections or surgical site occurrences that require some type of procedural intervention. And the first thing that I'm going to dive right into is smoking cessation, because I think that's the thing that our philosophy has evolved so much on over the past 10 years. The literature is pretty much saturated with larger and larger data sets that underscore the association of smoking with perioperative morbidity. And it's pretty difficult to find a manuscript that doesn't actively condemn smoking, at least in the perioperative standpoint. But most of these analyses get caught up in the statistical association of smoking with morbidity, and that only gets easier to demonstrate as larger administrative databases grow, because the larger the N, the smaller the p-value gets. I think what's often not addressed, though, is the magnitude of that association and whether or not it's clinically relevant, at least in the black and white way that we've come to treat it when counseling patients. So, to be totally transparent, we set out to perform this analysis in the ACHQC, thinking that we were going to throw another manuscript on the pile, so to speak. And we decided to look at open elective repairs in a clean setting and compare them, patients that were actively smoking to patients who had never smoked. And because the QC has granular operative details, we were able to propensity match nearly identical groups of over 400 patients based off comorbidities and hernia characteristics as well. And what we found in terms of raw percentages was actually quite shocking. Certainly, there was an increase in wound events for smoking patients in terms of wound cellulitis and seroma formation. But when it came to the more clinically meaningful variables, such as surgical site infection or procedural interventions, and all other types of wound morbidity, such as DVT events, pneumonia, the differences just weren't as remarkable as we thought they would be. And even when you look at the breakdown of infections, reoperations, and mesh removals, the differences just weren't as dramatic as we anticipated. And really, when you compare our results to surgeon-reported wound events compared to NSQIP, it's not as if our reported rates of wound morbidity were underreported. If anything, our wound event rates were higher than what we're seeing reported in NSQIP databases. And when you look at the subtle differences in the 30-day morbidity, what you start to appreciate is that the size of these 1 to 2% differences doesn't change. But, for instance, NSQIP has been around a lot longer, and it's got tens of thousands of patients. These differences are able to generate, an odds ratio with a pretty impressive p-value. So, what do we do with this information as we're accruing data? We interpret this data with some nuance. We don't discount the association of smoking with some mild increases in wound morbidity and all 30-day morbidity. We just don't think the magnitude of that impact, specifically in the setting of, again, this is clean, open cases, is enough to prohibit surgery in the category the way we once did. We do tell patients that it's in their best interest to quit at least 4 weeks before their operation, but we no longer check urine or cancel a case if they admit that they weren't able to stop smoking right before their operation. All right, moving along to probably the next most common thing, which is weight loss. This is probably one of the most predominant things that we deal with on a day-to-day basis. So I don't think it's a tough sell that BMI is certainly associated with wound morbidity, particularly in the context of abdominal wall reconstruction. It's probably one of the most modifiable risk factors. But what everyone really asks is, what's the cutoff? Patients and other surgeons, when we start talking about weight loss, the first thing out of their mouth is, well, how much do I have to lose? They want a defined endpoint. And I think most people, when you look at this expert consensus panel, they decided, sure, that less than 30 is safe and over 50 is certainly unsafe. But what to do for the folks between 30 and 50? Because to be honest, that's probably like 90% of the patients that are showing up in our clinics. So again, we tried very hard to find a cutoff using data from the ACH QC to guide this decision making. And again, we looked at open elective repairs with mesh, this time including all approaches and wound classes. And essentially what we found was a gradual, mostly linear relationship between BMI and both surgical site infections and surgical site occurrences requiring a procedural intervention, especially pretty much after a BMI of 26, which again doesn't really help much for our folks in the 30 to 50 range. So essentially our conclusion from that was that there is no magic cutoff. The more weight you lose, the better you're going to do. So, what do we do essentially from a practical standpoint? Our experience is that telling patients to come back when they've lost weight and are ready to go is a poor strategy. I think it's that this is really an opportunity when surgeons have the biggest chance to be real doctors and make lifelong impacts on their patients. We have patients set a goal. We document that goal in the chart. We shake hands on it, and we follow those patients every 3 months to hold them accountable to their commitment. My partners and I routinely often open repairs to folks with a BMI up to 35, and for patients over that, we treat on a case-by-case basis, depending on two things: the severity of their symptoms, so for instance, if they're having significant pain and bowel obstruction events, and the sincerity of their effort. For instance, we're going to treat a patient who lost 60 pounds to get down to a BMI of 42 differently than a patient who comes into clinic for the first time at a BMI of 42 and has not had a real opportunity to lose weight, particularly if they're not incredibly symptomatic. Okay, next real quick, we're going to review our approach to diabetes. So most of the early literature on this was from orthopedic and cardiothoracic literature looking at deep sternal wound infections. And it seems like the data found that pretty much somewhere in the 6.5 to 7 range, when you're talking about hemoglobin A1C, the patients are pretty much at the same risk as non-diabetics. Once you give above 8, however, it seems that your risk of a surgical site infection is double those who are patients who are less than 8. And so it's really, this is not a linear type relationship. This seems to be, exponential. So the higher the A1C rate, the wound infection rates start to go up dramatically. So our approach to this is we check a hemoglobin A1C preoperatively. And we typically prefer to operate, again, with a little room of variability depending on the complexity of the case. We typically want an A1C less than 8. Those above 8, we will reevaluate every 3 months. If you get the sense that the patient needs better medical management and they're at the 9, 10, 11, 12 A1C range, those are ones that are probably not just going to be able to watch their diet and make a huge change. They're probably going to need some medical help as well. And so usually those folks will get in touch with an endocrinologist because they just need some bigger moves. And then again, this is another huge moment where you have, you have a carrot offering them an operation, and it's a teachable moment where you can make, kind of lifelong impacts on their health, much more meaningful than just fixing their hernia. All right, I'm next going to go over a few things very briefly, and that's our stance on preoperative chlorhexidine. We do no longer do this because our data actually showed that it increased wound event rates in well-matched patients. Right now, we're actually in the middle of doing an interim analysis. So we're looking at the surgeons who stopped using chlorhexidine after this analysis, and we're seeing if those patients seem to have an uptick in wound events. Just as a little preview to that, it does not seem like that is the case, and we'll be publishing that in the near future. Finally, we also looked at data on bowel prep, and in well-matched groups similarly found that less is more. Patients without a bowel prep similarly had fewer wound event rates. So I know that's a lot of information in a short amount of time, and I hope that I was able to convey our perspectives on optimization. Smoking is still bad, but I think if we're being honest, at least in the context of clean, open cases, probably not as bad as we often regard it. For patients with a BMI in the 35 to 45 range, again, I think that the two keys are how severe are the patient's symptoms, particularly when it comes to obstructive symptoms, and how sincere was their effort to lose weight. Typically for an A1C, we shoot for less than 8. And when it comes to chlorhexidine and bowel preps, less seems to be more. So I thank you for this opportunity to present, and hopefully I'll be able to answer some of your questions as well.
So, hello, my name is Micki Reinhorn. I am a hernia surgeon in the Boston area. I've been asked to give a talk about tissue repairs. Is it old news or is it really the new future? In terms of disclosure, I really don't have any financial disclosures. However, about 5 years ago, I attended business school, and in the process, I visited the Shouldice Hospital in Toronto. And I went up there to learn their business processes, and I actually fell in love with the surgery and the language they use in describing inguinal anatomy. So I do give them some credits for that. I do not work at the Shouldice Hospital. So this slide is meant to be a little bit funny, but I think it's how the modern world looks at hernia surgery, at least in the United States. At least when I was taught hernia surgery, I was taught that tissue repairs on the left side were pretty archaic and old-fashioned, and only mesh repairs were worth learning about. And we've advanced so much so that we think robotic repair may be the end-all be-all of hernia repairs. Is that true? Well, let's look at what the data show. The main outcomes that patients are looking for is really an improvement in their quality of life, but we look at recurrence rate and chronic pain rates. And unfortunately, disability in inguinal hernia repair can occur permanently in 1 to 3% of patients. And where does that come from? And so when we look at our mesh repairs, open anterior, the Lichtenstein repair, the risk of recurrence is pretty low. It's 1 to 1.5. It's a great repair, but there's a chronic pain rate that can be anywhere from 6 to 30%. That's really for the first year. And this is data that came out of the International Hernia Guidelines a few years back, looking at a wide body of evidence. When looking at laparoscopic repair, the risk of recurrence may be a little lower. It's a posterior repair. It's more solid, but the risk of chronic pain can be quite high. I mentioned the Kugel repair, the open posterior repair, only because it's the main repair that I perform, but also that does get performed elsewhere around the world. It also has a low recurrence rate, similar to laparoscopic, maybe even lower, but it still has some chronic pain. And then the Shouldice repair has 2 different numbers for its recurrence rate. The first one is what's widely published, which is 2 to 3%, certainly higher than laparoscopic, maybe even higher than Lichtenstein. But when you go to the Shouldice Hospital, where their surgeons perform 500 cases a year, their recurrence rate is 1.15% over 30 years. Very few surgeons have that long of data unless there's national hernia registries, and their risk of chronic pain is lower than anywhere else. When I observed the Shouldice surgeons performing Shouldice surgery, they identified the 3 anterior nerves every single time in 7 cases that I observed. And so I think there is something to be said about knowing meticulous hernia anatomy as a way of improving outcomes. And so we're in a world where we now have apps created for the iPhone to forecast chronic pain after hernia operations, something that really wasn't that existent with tissue-only repairs, because surgeons really perform meticulous anatomical operations. And so really the questions for the audience is, do you think it's acceptable to have an app to find the risk of chronic pain, or can we reduce chronic pain? My answer is, I'm continually learning hernia anatomy, and I think we can reduce the risk of chronic pain by doing tissue repairs, or at least knowing what they are. And so the other component is, especially in the United States, but all across the world, is cost. When you do a non-mesh repair, a tissue-only repair, the disposable costs are really the suture. And that can be as little as $20. At the Shouldice Hospital, they spend $23 in equipment per operation. When you look at some of the mesh repairs, especially laparoscopic or robotic, you have disposable equipment on top of the mesh costs, and that doesn't even include the capital costs of a robot. In the US, insurances were lobbied and have increased the reimbursement for laparoscopic repairs. And is that good for our society? And so with that, I want to dive in and say a tissue repair may not be for everyone, but I think we should all know it and understand who it's good for. So I'll briefly mention Bassini and McVay, because those are the repairs that most of us learned in our surgical training. You know, the Bassini, both the Bassini and the McVay repair are interrupted sutures with fairly large bites of tissues that incorporate the rectus abdominis medially, the transition to the internal obliques more laterally, and then inferiorly the inguinal ligament. I'm going to refer to it the inguinal ligament, but it is really the reflection of the external oblique, is that it reflects down to become the inguinal ligament, the shelving edge, Houpart's ligament. It's all one structure. It's really the external oblique. In a diagram from Bassini, you can see that the sutures actually incorporate a little bit deeper than the inguinal ligament. They do incorporate Cooper's ligament, which is the way one would close the femoral hernia. And in the diagram in the middle on the McVay repair, you can really see just Cooper ligaments being closed with sutures. I'm going to show a slide in the next, what I see as the main differences between these repairs and the Shouldice repair. But at least in this slide here, you can see that the Shouldice repair is a running repair. The bites of the tissues are not huge bites. They're very close together, and it's performed in 4 layers. I'll get to that in another slide. One of the key differences with the Shouldice repair is the cut end of the cremaster muscle fibers. And this is a move that I've only seen at Shouldice Hospital. I've now repeated it with great success. When the cord is reflected and encircled either as a Penrose drain or just retracted over, there are loose cremaster muscle fibers, they're cremaster vessels, and the genital branch of the genital femoral nerve all along the floor of the canal. If those fibers are left intact, one of 2 things can occur. One, there's a higher recurrence rate for the hernia because the visibility isn't as good and you're not using the cremaster muscle fibers to create a new internal ring. The other thing is there's a higher incidence of chronic pain by trapping the genital branch of the genital femoral nerve. So the main difference with the Shouldice repair here is that by dividing these muscle fibers together with the neurovascular bundle of the cremaster, you're reducing the risk of chronic pain and reducing recurrence. One other highlighted difference is the way the incision is closed, and recent literature has supported a nice tighter closure together. And if you look at the analogy of a spiral notebook versus a 3-ring binder and decide if you pull a piece of paper out of one or the other, which is easier? It's a lot easier to rip a page out of a 3-ring binder than a spiral notebook. And so the Shouldice repair is much more like the spiral notebook repair. It's a tighter repair. And so I think that would be the procedure that I would recommend people learn to have in their armamentarium. So I'll briefly go over the Shouldice repair here, paying special attention to the nerves. It is a 4-layer repair. And one of the highlights is that the dissection is very similar to a regular Lichtenstein or another anterior approach. Some of the key differences is the external oblique is mobilized completely down to the leg to give it some flexibility, and about 5 centimeters of external obliques are left on the inferior portion of the leaflet to be used in the repair because it's used as a subsequent layers as part of the repair. The next real key component after doing a usual dissection is really clearing the floor and dividing the cremaster stump. That gives easy access to the floor of the canal. The floor or transversalis fascia and aponeurosis of transversus abdominis is actually cut longitudinally to get access to the preperitoneal space and identify if there's a femoral hernia. If there is, sutures are taken down all the way down to Cooper's ligament, often closing the external oblique to Cooper's, making this truly an approach for all 3 defects. The first layer of the Shouldice incorporates transversalis fascia sutured to the underside of the rectus abdominis. That's depicted in a picture on the left. And the final suture incorporates taking that cremaster stump, bringing it underneath the internal oblique and making a new internal ring. The second layer just runs the sutures back from laterally to medially, and a knot is tied medially overlying the pubic tubercle. The third and fourth layers are really a repeat, but they start from lateral to medial. So the picture on the right shows the knot laterally near the internal ring and the suture being run medially. Again, healthy bites of external oblique are taken mostly to the rectus abdominis, to the rectus sheath, but some into the internal oblique muscle as well. And the final layer, the external oblique, is just loosely brought over that rectus abdominis. You really are reconfiguring the anatomy of the rectus insertion. It's making it wider. In all of these pictures, the ilioinguinal nerve and the iliohypogastric nerve are drawn in the same location. There is some variability of these nerves, but the ilioinguinal nerve generally is more lateral, and the iliohypogastric always medial, always running along the rectus and always perforating the external oblique. If I can't find the iliohypogastric, I lift up the rectus abdominis, the external oblique, to see where it's perforating out and then trace it backwards. There is sometimes a need to divide anywhere from 1 to 3 of these nerves if it's inadvertently sutured or you can't get it out of the way. The genital branch of the genital femoral nerve is always cut. In terms of patient selection, not every patient looks like the picture that I drew here, but if they're athletic, they generally don't have a lot of adipose tissue, and the anatomy should look very much like the textbook. In terms of age, I typically offer it to the younger age groups and to the older age groups. And oftentimes for women, we offer it first, especially if they're thin, because they do tend to feel the mesh in our experience more, especially retroperitoneal mesh. And so, and a lot of women are coming in and asking for no mesh repairs. Patients who've had previous retroperitoneal surgery and are thin, they do not require a Lichtenstein repair, are excellent candidates for this. Patients who are motivated to avoid mesh for whatever reason. But it's critical to set patient expectations. First of all, we don't take on patients who don't meet this criteria. And it's a more painful repair. By suturing all these tissues, it hurts more than a Lichtenstein or any preperitoneal wrap, whether it's lap or open. It does hurt more. We tell patients they're going to have significant pain for 5 days. That pain is going to be managed with Tylenol and Motrin in over 90% of the patients. But patients have to have that expectation. They also will feel tight for several months after surgery in some instances. So to kind of summarize everything that I've talked to you is that when you look at the data, the blanket statement that mesh is the only way or the best way to fix a hernia, the data doesn't really support that. And so I think it's really critical for all surgeons to learn one of the non-mesh repair options. It's critical to understand anterior hernia anatomy if you're doing anterior repairs. You ideally need to see all 3 nerves. Every case, the genital femoral nerve is oftentimes buried in the cremaster muscle and you'd have to look for it. But if you know the anatomy and you know it's there and you know you're going to divide it, you don't have to see it. You just have to know that you're dividing it. When doing these repairs, patient selection is critical. If you do it on the wrong patients, they will have a recurrence. And then special situations, failed posterior repairs, radical prostatectomy, people who are anticoagulated that you may and cannot stop it, and you may want to do a repair while they're still on anticoagulation. This is a reasonable option for. And then finally, set the patient expectations. It just hurts more. We set the expectation that there will be numbness in the area. We used to have patients really worry and perseverate over it. But the way we counsel patients now is that numbness is typically temporary, it's a small area, and it's a very small price to pay to avoid chronic pain. And then finally, we tell them all that we may end up having to do either an anterior or posterior mesh repair in case we encounter issues with doing the surgery. And then finally, I want to thank my office staff. They helped me with some of the research and putting the slides together. Our 3 medical assistants, Wanda, Elizabeth, and Bailey, are all applying to PA school and medical school and have been in the operating room with me and helped put this together. Lauren, my PA, is my first assistant. That is a critical component of success in these operations, is having a first assistant that knows the anatomy as well as you do and can point out your mistakes when you make them, so that you can correct them before leaving the operating room. And finally, Samer Savai, who's a fellow surgeon who was invited me to the Shouldice Hospital while we were at business school together, has shared his operating room with me and has given me feedback in my operating room on my Shouldice technique, and is really my Shouldice mentor when I first started. So thank you for listening. My email is mreinhorn@bostonhernia.com. I'm happy to answer questions.
Hello everyone, and thank you so much for the opportunity to present to you today. My name is Dr. Rana Higgins, and I am an Associate Professor of Surgery in the Division of Minimally Invasive and GI Surgery at the Medical College of Wisconsin in the United States. Today, I'm going to be talking to you about MIS inguinal hernia repairs, robotic and laparoscopic. My disclosures include I am a proctor and speaker for Intuitive Surgical, and I am also a speaker for W.L. Gore. Inguinal hernias are ubiquitous around the world, as we all know. Over 20 million inguinal hernias are repaired worldwide every year. 700,000 inguinal hernias are repaired yearly in the United States. As we all know, men have a higher lifetime risk, between 27 to 43%, and women have a much lower risk of about 3 to 6% of an inguinal hernia at some point in their lifetime. It's obviously significantly more common in men, 8 to 10 times more common in men, with a peak prevalence at 5 years and as well as later in life between 70 to 80 years of age. Now, the classic open inguinal hernia repair that's most commonly performed is the Lichtenstein repair, which came about in 1984. It's a tension-free open repair using mesh. You can see here from the pictures on the side of the screen, isolating the spermatic cord and the ilioinguinal nerve, and then using that mesh to essentially reinforce the direct and indirect space going around the spermatic cord using a polypropylene mesh. So that is the standard open inguinal hernia repair that's most commonly performed. Now, laparoscopic inguinal hernia repair came about in the 1990s. There are two different approaches. There is the TAP, also known as the transabdominal preperitoneal repair, and there's the TEP, the totally extraperitoneal repair. On the bottom of the screen, you can see images of a TAP procedure. On the left, showing you the important structures to keep in mind. You can see there's a inguinal hernia here, and then on the right, you see that peritoneal flap that has been taken down as part of the repair to get into the preperitoneal space. So today I want to talk to you a bit about open versus laparoscopic inguinal hernia repair, and I want to talk as well about robotic inguinal hernia repair. So when talking about open versus laparoscopic inguinal hernia repair, there's numerous studies out there. This was a meta-analysis published in the World Journal of Surgery in 2018. It was a meta-analysis of 13 randomized controlled trials over 2,500 patients. And what they found was that there was no difference between hematoma, seroma, urinary retention, infection, or recurrence when looking at laparoscopic inguinal hernia repair compared to open repair. Now specifically, so those are the complications related to the surgery, but specifically when looking at paresthesias or groin pain after the surgery, a laparoscopic repair from this study did favor a lower rate of paresthesias. As you can see here from this meta-analysis, the risk ratio was lower, favoring the TAP or the laparoscopic inguinal hernia repair compared to the open. Now, specifically looking as well at return to normal activities and return to work, this was significantly less with a laparoscopic repair compared to an open repair. A laparoscopic repair had a shorter return to work and normal activities. Return to work was about 8 days for a laparoscopic repair compared to 17 for an open repair, and return to work was 16 days compared to 26 days for an open repair, both of which were statistically significant. So what was concluded from this study is that laparoscopic and open inguinal hernia repair have equivalent postoperative morbidity and recurrence rates. However, It has been found, and this has been found in multiple different studies as well, that laparoscopic inguinal hernia repair has faster recovery and decreased rate of paresthesias from a quality of life standpoint. So there are numerous studies, as I mentioned, out there looking at open compared to laparoscopic repair. Overall, the main conclusions from the literature is that there's no definitive evidence that there's any difference in recurrence or perioperative complications between open and laparoscopic repair. There are, though, numerous studies that do demonstrate improved functional status, earlier return to work, and less short-term groin pain in the laparoscopic compared to open group. So those are the main conclusions from the vast body of literature comparing open and laparoscopic repair. So what are the recommendations? So this was the Hernia Surge group put out these international guidelines for groin hernia management that was published in 2018. It's a conglomeration of guidelines from numerous societies, hernia societies around the world. So these are their statements and recommendations. They stated that when the surgeon has sufficient experience in the technique, laparoendoscopic techniques do not take longer than Liechtenstein operations, so similar operative times. The second statement they made was that when the surgeon has sufficient experience, there was no difference in perioperative complications, including reoperation. And their final statement was that laparoscopic techniques have less chronic pain and a faster recovery than the Liechtenstein or the open repair. So those are the main recommendations and conclusions when comparing open versus laparoscopic repair. Robotic inguinal hernia repair is obviously newer on the horizon. A way to approach a robotic inguinal hernia repair is through a TAP approach. The instruments are obviously wristed, so you have 7 degrees of freedom. This is an example at the bottom of what that would look like, and that blue line represents the peritoneal flap that you would make for a TAP repair. What are the clinical outcomes that have been found in the literature when looking at robotic inguinal hernia repair? So this was a large study, the most recent study published in JAMA Surgery of 2020. It is the first and only multi-center prospective randomized clinical trial comparing a laparoscopic versus robotic TAP. This was 6 sites, over 100 patients. The patients specifically had a unilateral primary or a recurrent inguinal hernia, and the patients were randomized to a laparoscopic or robotic approach. This is called the RIVAL trial. What the study found was that there were no differences in 30-day outcomes, including wound events, readmissions, pain, or quality of life. This study was also unique in that it looked at ergonomics, comparing laparoscopic and robotic repairs. There was no difference found there. What was found was that the robotic approach had increased operative time, 75 versus 41 minutes, and specifically the OR time that was greater in the robotic compared to laparoscopic repair was the hernia dissection, the mesh fixation, and the peritoneal closure. There was also a difference found in median cost, around $3,200 compared to $1,400, and this included OR costs and disposable costs. So this increase in OR time and cost is something that we're seeing a lot in the robotic compared to laparoscopic literature, so that was something that was found in this study as well. The study also looked at NASA TLX scores to measure frustration level, and that was found to be significantly greater in the robotic group compared to the laparoscopic group. None of the other NASA TLX parameters were different, but frustration level was slightly greater for the robotic group, and that was significantly different. So what was concluded from this study was that there was no clinical benefit to the robotic approach to straightforward inguinal hernia repair when comparing to the laparoscopic approach. It was also found that the robotic approach incurred higher costs and more operative time with added surgeon frustration and no ergonomic benefit to surgeons. This was another study recently published in 2020 on behalf of the Prospective Hernia Study Group. This was 17 institutions, over 500 patients, randomized, not randomized, but it was retrospectively analyzed, robotic, open, or laparoscopic. And essentially what they found, comparing the robotic versus laparoscopic group, there was increased operative time, again, in both unilateral and bilateral groups, comparing robotic to laparoscopic. This study was unique in that it looked also at pain and time to return to activities. So neither the number of pain pills nor the time to return to normal activities were different between the robotic and laparoscopic group. Those were comparable for both groups. When comparing robotic to the open group, the robotic group did have increased OR time, but only for bilateral repairs. The robotic group had improvement in quality of life in that patients took a decreased number of pain pills and had a decreased time to return to work and to normal activities when comparing robotic to open. Now, looking at quality of life at 3 months and postoperative complications, these were the same and comparable for all 3 approaches in this study. So what was concluded from this study is that inguinal hernia repair can be performed effectively using a robotic, laparoscopic, or open approach. Operative times were longer when comparing robotic versus laparoscopic approach, and time to return to normal activities was the same, essentially, for robotic and laparoscopic approaches, both of which were sooner compared to open. So the main conclusions from the literature, I just mentioned a couple of studies, but overall the main conclusions were that there's a similar overall complication profile between robotic, laparoscopic, and open inguinal hernia repair. Robotic inguinal hernia repair does have increased operative time and increased cost, and we really need to continue identifying the role of robotics in inguinal hernia repair compared to laparoscopy. So in conclusion, laparoscopic inguinal hernia repair has clinical benefits over open with less chronic pain and faster recovery. Robotic inguinal hernia repair offers another MIS repair option. And one thing to consider is what is the difference in the learning curve compared to laparoscopy? We all know that laparoscopic inguinal hernia repair has a very steep learning curve, and this has really been yet to be very clearly defined for robotic inguinal hernia repair. And obviously, robotic inguinal hernia repair research is still evolving. Thus far, no inferior clinical benefit has been established, but we really need to consider cost and operative timing as well as the learning curve. Thank you so much for the opportunity again to present today, and I'll take any questions.
So I'm Thue Bisgaard from Denmark. I'm a surgeon, and I have been involved in hernia surgery for almost 20 years and being a board member of the Danish hernia database. I have no disclosures, and first I would like to attend to a recent systematic review reporting outcomes in incisional hernia surgery. A lot of patients, almost 12,000 patients, were implicated in this analysis, and what the authors find was a significant heterogeneity in hard outcomes like complications, readmittance, and stuff like that, but a significant underreporting of patients' reported outcome were involved in all these many patient studies. Patient preoperative complaints and indication to offer an elective hernia mesh repair should be offset by the risk of postoperative complications. In a 10-year-old study in Denmark nationwide, it was actually found that incisional hernia repair was quite dangerous. We had, within the first 30 days follow-up, 11% of surgical complications, of which 3.5 were very serious complications. And surprisingly, within the first 30 days, 1 out of 250 patients actually died after the operation. Now, in long-term study like this one, published 5 years ago, mesh-related complications were studied. And surprisingly, after these 5 or 6 years, there were about 5% severe mesh-related complication, which required an surgical intervention. So again, these hard outcome complications should be balanced if patients actually gain from an elective ventral hernia repair. Now, I'm going to the soft outcomes to define them and to see what evidence we have in hernia mesh repair. There are actually 3 different patient complaint data types. It is PROMs, which is actually isolated symptoms and complaints before this operation and after the operation. It may be pain, fatigue, bulging symptoms, sexual dysfunction, and so on. And we also have PRO data, which is defined actually as an umbrella of questionnaire. Within this umbrella, it may be procedure-specific quality of life, like the AAS questionnaire and other questionnaires, and also combined with generic quality of life, like the short formula 12 or short formula 36, etc. And now, within the last few years, a MIMA measures your self-medical outcome profile. That is a complete new form of isolated symptoms complaint. And the first 2 ones up here, the thing is that they're not defined by the patient, but by the surgeon. Not talking, well, they have been talking, but it's defined by the surgeon. The last one here is actually what the patient says, what the patients say they have for problem before the operation. So that's a completely different thing. One thing, if you register preoperative symptoms and compare them with postoperative, you actually have to measure the same symptoms before and after. And you have to measure them in the same way, that is by telephone interview, by patients themselves, filling out a questionnaire, etc. That's very important. Otherwise, you don't have any possibilities to see what the operation actually did to the patients. There are 4 scenarios in elective ventral hernia repair. The first one is you have a symptomatic, highly symptomatic patient. He is operated and the symptoms are minimized. That's a good thing. The other one is that you have a highly symptomatic patient, but the operation does not change his symptoms. And the third one is you have a patient, an oligosymptomatic patient, which have been offered an operation and the operation doesn't help him at all. All he is at risk for having a complication somehow. And the last one and the worst one is that you have the operation and the patient will get worse after the operation. I have, at least myself, experienced that in some of my patients. Now, this study is, again, a systematic review focusing on pre versus post-operative changes of PROMs. Before study, we defined 3 different criteria. Clinically relevant change, it's not based on p-value only, but it's clinically relevant. And we have possible relevant change and not clinically relevant change. I will now go into the clinically relevant changes. We had almost 3,000 or more patients included in 39 study arms. The median follow-up was 12 months. The study quality, unfortunately, in all these studies were of poor, very poor, or what we characterized of moderate. It was not too good, and only 1 high quality study. There were 20 different outcome measures, like, for instance, sexual quality of life, fatigue, heaviness, pain, feeling of fullness, etc., etc. The good thing of, you may say, but it's also ridiculous, but the good thing is that the repair at least did not deteriorate PROMs in any of the studies. Hooray, hooray. So what about umbilical hernia repair? Did that help the patient to have this operation, at least in this analysis? No. What about the medium-sized incisional hernia repair? Did that help? No. What about then the giant hernia repair? Did that have any clinical important effect? Whoa. Well, at least in physical impairment and pain it helped, but nothing but all the others, nothing of all the others. So in conclusion, disappointing. Only a subset of PROMs and PRO data actually improved in a clinically important way at least 3 months after the operation. Now, why was these findings there? You maybe speculate, but actually I think it was due to the studies being of bad quality. I may speculate that it was too short follow-up. Maybe the authors of this study used actually incorrect PROMs. It was not PROMs defined by the patients like the MIMAP. Maybe different results if they used MIMAP, but there are no data out there. So maybe the wrong patients were put to an operation, and thus the indication to repair may be not the right one. And last, I don't know, we like to think it's not an option like surgeons. We like to think we do good, but maybe a hernia repair often doesn't cure the patient from the preoperative symptoms. Now, for future studies, I think, of course, high quality studies are imperative. As surgeons, we like to do good, and we like to prove that there is a good quality in our treatment, because we have to counteract all those complications that we may meet. MIMAP evidence is desperately needed in hernia surgery, and we need to know who will gain from hernia repair, which sometimes is a big operation. So we need predictors, and we need validated questionnaire with this procedure-specific thing in hernia repair, and we need to do it on MIMAP experiences from the patients to put in these variables in the questionnaire. And finally, almost, I think it is a difficult task, but I think we should have high impact data, high number of patients from our hernia registers registered with preoperative and postoperative PROMs. This is a very difficult task to do. And what about the patients with watchful waiting approach? How are they doing along with the time? Are their PROMs and MIMAP worse or doing better along with time? Bye-bye.
Well, thank you to Dr. Michael Rosen and Advances in Surgery for the invitation to speak today. My name is Arielle Perez, and I'm going to be going over umbilical hernia repairs, mesh versus no mesh. I have no relevant disclosures. As an overview of what we're going to be talking about today, we'll go over a little bit about umbilical hernias, a nice quick repair algorithm, a little bit about mesh, a little bit about suture repair, minimally invasive repair, repair in specific populations, and then we'll go with some conclusions. So in the 2000 New England Journal of Medicine article, Liang et al. Published preliminary findings of a randomized control trial comparing suture repair to mesh repair. And after 3 years, they found that mesh use reduced the incidence of hernia recurrence from 43% to 24%, regardless of the size of the hernia. And in a subsequent 2004 Annals of Surgery article, Berger, Lewandike, and colleagues published their long-term results of the same study, demonstrating a 10-year cumulative rate of recurrence going from 63% for suture repair down to 32% for mesh repair. These, along with multiple other studies, have solidified the notion that mesh repair reduces the incidence of hernia recurrence by almost half. So why don't we always use permanent synthetic mesh? Well, a big reason is because of mesh complications, which have been well documented, both short-term, such as surgical site infections, seromas, hematomas, and bowel adhesions, and long-term, such as mesh extrusion, chronic draining sinuses, and mesh erosion leading to an enterocutaneous fistula. As well, mesh requires dissection of tissue planes for proper mesh placement. And for umbilical hernias, there's a big question of if it's really necessary for all hernias, even the small ones. So with umbilical hernias, the question is often whether we should perform mesh repair or not use mesh at all. With umbilical hernias, we know that up to 25% of the population has an umbilical hernia, has an asymptomatic umbilical hernia. In the United States, every year, approximately 175,000 umbilical hernias are repaired. For clarity, we must define the difference between a primary umbilical hernia, where the defect is located in the midline with its center at the umbilical ring and is formed in the absence of prior tissue trauma, compared to an incisional umbilical hernia, which could be anywhere from 3 centimeters above to 3 centimeters below the umbilicus, and is formed in the setting of a prior fascial incision to the site. As a broad overview, these two distinct types of umbilical hernias should be managed in separate ways. For incisional umbilical hernias, they should be thought of and managed differently than primary umbilical hernias. They should be, despite the location and no matter the size, treated like a true incisional hernia. Today, we'll be focusing mainly on primary umbilical hernias and whether or not we should use mesh. The first decision point is whether it's an elective case or an emergency case. Looking specifically at elective cases, these patients should ideally have all their comorbidities optimized. Next, you'll want to determine, does the patient plan or want to have a future pregnancy? If so, this will lead to a specific patient management. For umbilical hernias in women of childbearing age, we know that in 2 Danish studies by Ohm et al., the prevalence of umbilical hernias during pregnancy was quite low, at less than 1%. However, approximately 15% of all umbilical hernias being repaired were in women of childbearing age. So in a nationwide retrospective cohort study using the Danish Ventral hernia database of over 250 female patients who underwent umbilical epigastric hernia repair with a subsequent pregnancy, there was no statistically significant difference in recurrence rates for mesh or suture repair, although mesh repair did have a higher recurrence rate. Neither BMI or hernia defect size was found to be an independent risk factor for recurrence after pregnancy. And in a small case study of 8 female patients who had a subsequent pregnancy after laparoscopic ventral hernia repair, 5 of the patients remembered a tearing or pulling pain at the area of the hernia repair during the last month of pregnancy, and 6 had a prior pregnancy for comparison and described more pain in the abdominal wall during the pregnancy after the mesh hernia repair. So, for elective female patients wanting a future pregnancy, umbilical hernia repairs should either be postponed or performed with no mesh, since mesh may actually increase pain and doesn't seem to provide any benefit over suture repair in terms of recurrence. In fact, in the recently published European Hernia Society and America's Hernia Society guidelines for primary ventral hernia repair, it was recommended the repair be postponed until after pregnancy, and preferably after the last pregnancy. And if it can't be postponed, that suture repair be used. Well, what about men or women that aren't wanting a future pregnancy? For elective primary umbilical hernia repairs, where the patient is fully optimized, there's low likelihood of a future pregnancy. The size of the defect is the next decision tree point. In primary umbilical hernias, size does matter when considering if mesh is necessary or not. Traditionally, 2 centimeters was the cutoff for mesh and umbilical hernia repairs. But in the 2015 cohort study from a single region in Denmark, Christoffersen looked at over 1,000 patients with primary elective open mesh or suture repair of small umbilical or epigastric hernias less than 2 centimeters. And they found that the recurrence rate was significantly lower in the mesh group. As well, in the 2018 randomized control trial by Kaufman et al. Lancet, looking at adult primary umbilical hernia repairs with either a suture repair with non-absorbable suture or mesh repair with a flat preperitoneal polypropylene mesh, they found the recurrence rate after suture repair was 3 times higher than mesh repair. Although the study was not powered to detect differences within subgroups, mesh repair was still found to be superior to suture repair for hernias greater than 2 centimeters, as well as hernias 1 to 2 centimeters in size. So based on those studies, it's recommended that for elective umbilical hernia repairs for defects greater than 1 centimeter, mesh should be used. Again, in the 2020 EHS-AHS guidelines, it's recommended that for elective umbilical hernia repair, mesh should be used, but suture repair can be considered for defects less than 1 centimeter. So for those small defects less than 1 centimeter, for the most part, usually these patients will get a primary suture repair. But for some patients, those with a high risk of recurrence, mesh placement should be considered and a lengthy discussion with the patient should be had. So why is the risk of recurrence so important, and does it even matter for these small, less than 1 centimeter umbilical hernias? Well, in a 2015 multi-center database study by Holohan and colleagues, after a 140-month follow-up, they found that 37% of primary ventral hernias had recurred. With each subsequent hernia repair, the rates of complications increased, and they found that SSI doubled the chance of hernia recurrence and quadrupled the chance of reoperation and set the patient back into a cycle of recurrent hernia repair. In order to tame this vicious cycle, the goal is to reduce the risk of recurrence while reducing the risk of infection. With mesh, the problem is that although you reduce the risk of recurrence, you're also increasing your risk of infection. So mesh use may or may not be beneficial in small umbilical hernias. Well, in the 2017 retrospective study of VA patients, Shanker and colleagues found that liver disease, diabetes, ascites, and primary suture repair were associated with increased risk of umbilical hernia recurrence. And in multivariable analysis, they found that obesity and ascites were associated with significantly increased odds of developing an umbilical hernia recurrence. In a different study, Donovan and colleagues looked at patients undergoing open umbilical hernia repair and found a statistically increased risk of recurrence with higher BMI, smoking status, diabetes, primary closure, postoperative infection, and concurrent laparoscopic inguinal hernia repair. So knowing the patient's comorbidities and risk factors prior to elective repair is important, and a decision on whether mesh used to reduce hernia recurrence should be weighed with the increased risk of mesh causing an infection. Patients with a small umbilical hernia and a high risk of recurrence should undergo shared decision-making between the surgeon and patient on whether mesh should be used or not. Well, what about emergency umbilical hernia repair? For emergency cases, the first decision point is the wound class. For a dirty case with a high risk of infection and most likely an unoptimized patient, mesh should be avoided. It's already a high infection risk, and we want to avoid the vicious cycle by limiting infection and recurrence, as well as marring of potential tissue planes. Although mesh reduces the risk of recurrence, it also increases the risk of infection, which in turn increases the risk of recurrence. For non-dirty cases, in an emergency case, remember the goals. Resolve the acute problem. Don't burn any bridges. Avoid the vicious cycle. So in a non-optimized patient requiring emergent umbilical hernia repair, don't use mesh. This will limit the risk of infection as well as limit the dissection of tissue planes and scarring that can make subsequent repair more difficult in the future. Well, what about optimized patients? For non-dirty, optimized emergency patients, you should treat these similar to your elective hernia repair patients, but stay cognizant of the potential increased risk of infection and whether mesh is reasonable for use or not. Remember the goals of your emergency repair. You want to resolve the acute problem. Don't burn any bridges and avoid the vicious cycle of recurrence and infection. And in both the 2020 EHS, AHS guidelines, as well as the 2017 Ventral Hernia Repair Expert Consensus published in Annals of Surgery, emergency ventral hernia repair should be individualized based on the patient and hernia characteristics. Okay, so that's the algorithm. Now, when it comes to mesh, questions are, should we use mesh? What mesh material should we use? What mesh form should we use? And where should the mesh go? We already know that mesh reduces the risk of hernia recurrence by almost half. And we also know that mesh increases the risk of infection. So should we use mesh? Well, yes, mesh should be used, but in the appropriate situation. Well, what about the mesh material? On the market today, there's a plethora of surgical meshes in three main categories. For clean cases, permanent synthetic mesh should be used during repair of wound class 1 hernia cases. It's a fraction of the cost of biologic and absorbable synthetic meshes. As well, there's no high-level data that demonstrates the superiority of biologic or absorbable synthetic mesh over permanent synthetic mesh. In contaminated settings, no synthetic, no biologic, and no absorbable synthetic mesh is FDA approved for use in a contaminated setting. Yet, we see surgeons, studies, and advertisements discuss the use of mesh in contaminated settings. In one such study by Dr. Warren and his colleagues performing a retrospective review in Greenville, South Carolina, of 541 ventral hernia cases in contaminated settings, the majority were done open using synthetic mesh. Mean follow-up was 46.6 months, and the results of the study revealed an SSI rate of 14%, 2.4% of patients required mesh excision, and less than 1% of patients developed an anterior cutaneous fistula. At 46.6 months, there's a 10.5% recurrence rate, and these outcomes are comparable, if not better, to other studies evaluating biologic and absorbable synthetic meshes. For contaminated cases, there have been multiple studies looking at biologic, absorbable synthetic, and permanent synthetic meshes, which is a separate talk in and of itself. But as a quick synopsis, permanent synthetic mesh does have a possible risk of infection and may require a mesh excision, but it has a lower risk of hernia recurrence. Biologic mesh increases cost, has a higher possible risk of infection, and higher risk of recurrence. And absorbable synthetic mesh increases cost compared to permanent synthetic mesh. It does have a possible risk of infection and carries a higher risk of recurrence compared to permanent synthetic. So what mesh material should we use? Well, if we're going to use mesh, it should be permanent synthetic mesh for primary umbilical hernias. Well, what mesh form should we use? There's flat meshes, there's barrier-coated meshes, there's plugs, and there's patches. In a multi-center European randomized control trial for repair of symptomatic primary small umbilical or epigastric hernia repairs, flat preperitoneal polypropylene mesh versus a Proceed ventral patch was evaluated. About 28% of all patients suffered from some sort of complication. But what they found was that flat mesh had lower rates of complications and reoperations. And in a prospective study of 28 patients with ventral hernias, less than 3 centimeters, undergoing repair with a mesh patch and recoil memory ring, subsequent laparoscopic evaluation of the mesh after placement showed cupping of the mesh so that it was not laying flat right up against the abdominal wall. So although it's not the strongest evidence, in the 2020 EHS-AHS guidelines, it was recommended that flat permanent mesh be used. Ideally, it should be used in the preperitoneal space with an overlap of 3 centimeters. So what mesh form should we use? It should be flat mesh with at least 3 centimeters overlap. And where should the mesh go? Well, mesh location will be dependent on surgical technique. It can be placed in an onlay, inlay, retromuscular, preperitoneal, and intraperitoneal space. But for umbilical hernia repairs, fascial closure should be achieved and inlay mesh should be avoided. In terms of mesh location, in the 2020 EHS-AHS guidelines, they recommended that preperitoneal placement be performed for primary umbilical hernias. So where should the mesh go? Ideally, it should be preperitoneal. Well, what about suture repair? In the 2013 retrospective study evaluating 162 umbilical hernia repairs with a 70-month follow-up, 77% of the patients were suture repaired using 3 types of techniques. There was no significant difference in recurrence rates among the 3 different suture repair methods. In a prospective cohort study using the Danish Ventral Hernia Database for patients undergoing small umbilical and epigastric hernia repairs less than 2 centimeters, when evaluating just the patients undergoing suture repair, the type of suture material was not statistically significant. However, permanent suture did have the best outcomes. And in a single cohort study by Christofferson looking over 13,000 patients undergoing primary elective open mesh or suture repair of small umbilical or epigastric hernias less than 2 centimeters, again, subgroup analysis of the type of suture material again was not statistically significant, but slow absorbing suture repair had the best outcomes. So with suture repair, there is no specific technique that is superior, and fast absorbing suture should be avoided. Going back to the 2020 EHS-AHS guidelines, suture repair can be considered for defects less than 1 centimeter, and slowly resorbable or non-absorbable sutures should be used with a suture technique left up to the surgeon. What about minimally invasive repair? In the 2017 systematic review by Hexadine and colleagues, comparing laparoscopic mesh to open umbilical and periumbilical hernia repairs in over 16,000 patients, open repair had higher risk of wound infection, wound dehiscence, recurrence, longer hospital stays, and shorter OR times. In a retrospective study by Williams and colleagues of laparoscopic and open umbilical hernia repair in obese patients, they found that laparoscopic repair was associated with lower rates of SSI, despite patients having higher rates of risk factors. And in the 2020 study from Hendrickson, looking at open versus laparoscopic umbilical and epigastric hernia repairs, recurrence rates were comparable between the 2 techniques, but open repair was associated with higher rates of readmission and reoperation due to SSI, while laparoscopic repair was associated with higher rates of reoperation due to severe complications. So with lower risk of infection but higher risk of severe complications, the EHS-AHS guidelines recommend MIS repair be considered for large umbilical hernias, as well as patients with increased risks of wound infection. For specific populations, such as patients with cirrhosis, although it may seem like an umbilical hernia, you always want to get imaging for preoperative planning and evaluation so you can check for possible varices. In a prospective study evaluating safety and effectiveness of umbilical hernia repair in patients with cirrhosis, cirrhotic patients had increased 90-day morbidity and post-op complications after emergency repair. In a retrospective review of the National Inpatient Sample Database of over 32,000 patients who underwent umbilical hernia repair, cirrhosis was independently associated with mortality, and subset analysis of cirrhotic patients showed that elective repair was protective from mortality. So with increased morbidity and complications after emergency repair, EHS, AHS guidelines recommend elective umbilical hernia repair in patients with liver cirrhosis after optimization of liver function, with open repair being performed and keeping mesh outside of the abdomen. Well, for patients on peritoneal dialysis, the 2014 SAGES guidelines recommend to diagnose and repair abdominal wall hernias before or at the same time as PD catheter insertion. You should minimize peritoneal dissection and avoid intraperitoneal mesh placement. And you would perform an open anterior repair with onlay mesh due to its low recurrence and leak rates. The EHS, AHS guidelines similarly recommend an open repair using either an onlay or preperitoneal mesh placement. So in conclusion, a repair algorithm for mesh use in umbilical hernia is mainly guided by patient and hernia-specific factors. For suture repair for umbilical hernias, this should be considered for umbilical hernias less than 1 centimeter, women planning on future pregnancy who require hernia repair, and for dirty cases. If suture repair is going to be performed, you should use a slowly resorbable or permanent suture. Mesh repair should be used on all elective, clean umbilical hernia repairs where the defect is larger than 1 centimeter. Patient and hernia factors should guide management to avoid the vicious cycle of hernia recurrence. Although mesh reduces the risk of hernia recurrence by half, it also increases the risk of infection. Infection after hernia repair increases the risk of hernia recurrence, sending the patient back into the vicious cycle. For women planning a future pregnancy, you want to perform a suture repair or postpone repair until all pregnancies are completed. For cirrhotic patients, elective repair should be performed after optimization of liver disease with an open technique, avoiding intraperitoneal mesh. And for patients on peritoneal dialysis, you want to perform an open repair with mesh in an onlay or preperitoneal space.
Thank you very much for the opportunity to present today. I'm Dr. Mike Liang, Professor of Clinical Sciences at University of Houston and the Surgery Program Director at HCA Healthcare at Kingwood. Today I'll be speaking about robotic IPOM ventral hernia repair. I have no financial conflicts of interest. Ventral hernias are a common problem, and unfortunately repair of them is associated with substantial morbidity, including recurrences and surgical site infections. Level 1 evidence demonstrates that laparoscopic or minimally invasive ventral hernia repair can decrease the rate of surgical site infections without altering hernia recurrence compared to open surgery. Despite this, the adoption of laparoscopic ventral hernia repair has been limited, and less than 1/3 of all ventral hernias are repaired utilizing a laparoscopic technique. Robotics may have a role in expanding this adoption. Robotics has the potential to increase adoption through superior optics, 3D visualization, increased degrees of freedom, and improved ergonomics. So the question is, does the evidence support robotics having a role in ventral hernia repair? When we look at all randomized controlled trials in abdominal pelvic surgery, a recent systematic review and meta-analysis evaluating this answered this question. It was a systematic review of nearly 50 randomized controlled trials of nearly 5,000 patients. It demonstrated that there was no difference in intraoperative complications, conversion rates, or long-term outcomes utilizing robotic approaches versus laparoscopic or open surgery. Robotics did take longer to perform procedures and came at a greater cost. When we're performing a robotic ventral hernia repair, we have the patient with both arms out near the edge of the bed that we're approaching, and commonly a bump will be placed under that lateral side. So in this situation, there's a bump under the patient's left side with both arms out. All the ports are placed in line laterally, 6 to 8 centimeters apart, and you can flex the bed to widen the space between the ports to allow greater space for the robotic arms to work. In addition, the bed can be tilted laterally to allow greater space from the ports and the hernia. So in this situation, the patient is placed in right lateral decubitus so that the left side of the abdomen is higher, allowing greater space. At that point, the robot is docked, and typically in the left arm, a bipolar is placed, and then in the right arm, a pair of scissors with cautery is inserted. First, upon entry, you start with a lysis of adhesions. Here you can see the abdominal wall, the junction between the abdominal wall and then the omental adhesions, and here is the robotic scissors. As the adhesions are taken down, the hernia is exposed until finally the hernia is almost completely exposed and the contents are reduced. Next, we close the defect. Typically, we'll use an O locking suture with 12 or 18 inches in size, and oftentimes more than one is needed. The sutures are placed, and then after a number are placed, the gas can be deflated down to 8 millimeters of mercury, and then the sutures can be tightened. And here you can see after placing all the sutures, they're pulled down to close the fascial defect. We follow this with mesh placement. We use the same size mesh with 5 centimeters of overlap prior to the defect being closed. Oftentimes, many surgeons will utilize much smaller mesh, but in our practice is to use a mesh of 5 centimeters of overlap prior to defect closure. And then the mesh is sutured and secured circumferentially utilizing a 2O locking suture. What's the evidence on this approach in robotic IPOM surgery? We performed a randomized controlled trial comparing robotic versus laparoscopic ventral hernia repair. This is the 1-year results from this prospective multi-center trial. 124 patients were enrolled and randomized. In the short-term results, robotics had longer operative duration, almost double the length. It was also associated with more enterotomies. This was not statistically significant, but clinically significant, as well as substantially increased healthcare cost. There was no other differences in short-term outcomes. At 1 year, we noted that there was no difference in recurrence. However, there was a significant difference in reoperations, with no reoperations in the robotics group, but more in the laparoscopic group. Again, this is a secondary outcome. It could be due to chance. It should be considered hypothesis generating. In another trial, the Prove-It trial, the Cleveland Clinic group performed a prospective randomized controlled trial comparing robotics versus laparoscopic ventral hernia repair, utilizing a similar technique. They randomized 75 patients. In the short term, they noted that robotics had, again, a longer operative duration, similar rates of enterotomies, 5% in both groups, as well as greater hospital cost. Essentially the same conclusions as our trial had. Their 1-year results are pending and should be presented and published this year. Limitations of both studies: they were both highly skilled surgeons and particularly at laparoscopic surgery. Many would consider them on the level of experts, having performed thousands of procedures, whereas they may have been considered more likely proficient, having only performed hundreds of robotic surgeries. In addition, the surgeries were typically complex recurrent hernias in higher risk patients. So why did we see no benefit with robotic ventral hernia IPOM versus laparoscopic IPOM? Part of the issue could be space, in that with robotic ventral hernia repair, oftentimes there is limited space to work, and the robot tends to do well when there's a lot of space and a great deal of distance between the robot and the operative field. In the end, some reviewers had noted that both trials essentially were comparing IPOM suturing versus IPOM tacking, and essentially they didn't maximize the potential benefit of robotic surgery. Alternatives to IPOM include preperitoneal repairs, which typically work best with smaller hernias, retromuscular or ETAP. There are concerns of anerotomies, violating a potential space, particularly for smaller hernias, or retromuscular transversus abdominis release or robotic TAR. These are associated with longer operative durations, excessive use of component separations. Oftentimes, surgeons are performing component separations for defects less than even 6 centimeters, whereas in any other setting, we would only perform a component separation for an 8 or 12 centimeter defect, and questionable benefit for the patient. None of these three approaches have undergone the rigors of a randomized controlled trial. And issues with adoption. There's need for high quality evidence with extended follow-up prior to widespread dissemination of any of these other approaches. So what's the role of robotics in hernias? For small defects of primary hernias, such as umbilical or epigastric hernias, oftentimes I'll perform a robotic preperitoneal repair. Patients who want to avoid tacks and desire to have suture-based repair, and in challenging situations. For example, robotics was successful in inguinal hernia repair in adoption because it provides lots of space from where the robot is docked versus where the surgery is performed. It simplified the dissection for non-high volume surgeons, and the robotic suturing made it easier compared to laparoscopic suturing. So for example, at my institution, almost all of the physicians perform robotic inguinal hernia repairs because of its ease compared to laparoscopic repair. So in closing, robotics appears to have a future in surgery and hernia repair. It currently lacks clear-cut benefit, but in many specialties, doctors and surgeons clearly believe that there's a role for robotics, including urology, colon surgery, thoracic surgery, inguinal hernia. And now of increasing discussion is its role in ventral hernia repair. Randomized controlled trials with short-term and long-term follow-up are needed prior to widespread dissemination and adoption, particularly of new techniques and approaches. Thank you very much for the opportunity to present today.
So, good morning, good afternoon. I'm Olivier Lefranc from Medtronic, and today we'll speak about the key attributes that we have on the mesh when we develop a new one. Obviously, I'm a Medtronic employee, but for today we won't speak about any commercial product. We'll just see science behind the main concept that we got on the meshes for today. Because we are speaking about hernia meshes, and hernia mesh is an implantable medical device. It means that it will be implanted into a living host, and doing that will have a reaction. It cannot be avoided. It's something normal. But this reaction, called host reaction, inflammatory reaction, whatever you call it, has to be considered and well known in order to develop the right device. So this inflammatory reaction is a cascade of cells and different molecules happening through a certain sequence. It's divided into two main phases. During the first phase of inflammatory reaction, called acute phase or inflammatory phase, whatever, you've got first the white blood cells, then macrophages, then fibroblasts who will enter into the theater. And at the same time, they will secrete some proteins and extracellular matrix as type 3 collagen, for example. And then after 7 to 14 days, you have the second phase of the inflammatory reaction. And when the second phase arrives, it's called reconstructive or remodeling phase, depending on different terminologies, then you will have some slight change. Fibroblasts will acquire a contractile phenotype, and you will have a molecular reorganization, like collagen 3 will become collagen 1, which is more organized and structured, as you can see on the graph on the bottom right of the screen. And blood supply will also enter into the theater in order to finalize and to close the wound and to have a stable wound. And if everything goes well, everything is kept under control, then on the top right of the screen, you can see the Douglas curve. The Douglas curve shows that you need nearly 90 days after a wound to heal and to come back only to 70 to 80% of the initial strength. So you do not come back to 100%. That's why you need a mesh. So when we keep all of that into mind, we know what are the main surgical outcomes for hernia repair. We know we want limited scarring, comfort, durability, we want integration, and in some certain cases, we also want visceral protections. And based on what we've seen, we know what are the main properties, main attributes of a mesh that we need to target. And today we'll speak about porosity and performance. We'll speak about some material and also some dual-sided mesh concept. But before entering into the main concept, one question is, what is porosity? Porosity can be defined by the microporosity. This is the tiny spaces between yarns in the stitches. All those tiny spaces has been described as being more than 10 micron. Why? Because it's a space needed for white blood cells to enter into the theater and protect the mesh against bacteria, for example. But the most important part is the macroporosity. The macroporosity are those voids that you can see through the meshes, all those big voids representing the porosity. European Hernia Society guidelines describe that it has to be more than 1 millimeter to avoid encapsulation. Why 1 millimeter? Look at the scheme on the left-hand side on the screen, and all the white circles is the mesh cross-section. It comes toward you. During the first phase of inflammatory reaction, you have some granuloma around each yarn. If you don't have enough spaces between the yarn, the granuloma will bond and will generate a plate around the mesh. It would not be a problem if you did not have this second phase of inflammatory reaction. Remember, collagen 3 turns into collagen 1, fibroblasts will become contractile, and then it will shrink. It will shrink to close the wound. And by shrinking, it will take the mesh with it. A mesh does not shrink, but the tissues around the mesh can shrink and take the mesh with it, with all the problems we know. If you have more than 1 millimeter, you have exactly the same phenomenon. However, the granuloma won't touch each other. So during the second phase of inflammatory reaction, it will shrink around each yarn without taking the mesh with it. So you can have 4–5% of shrinkage due to some conformation of the mesh, but not the 30 to 35 or even 50% that you can observe in certain cases. And one thing also which is to take into consideration is the pore shape. It's been described as hexagonal pore shape is the best one because it limits the deformation. Whatever the direction you stretch the mesh, it will remain open. But you should be careful about not stretching too much the mesh when you place it. We know there are often some confusion between porosity and weight. And weight is very different than porosity. If you look at the table which is here, the second lightest mesh is also the one with the smallest porosity. And if we plot them on a graph with the weight, surface density on the x-axis, and the pore size, porosity on the y-axis, you see no correlation at all. However, we know that the weight, surface density, is highly correlated to the performance, mechanical performance of the mesh on the y-axis. So if you only consider the weight, then you may have the problem of being too low in terms of mechanical performance. And if I come back to my table, the lightest of all, the mesh C, is also the weakest one. It may have been too weak for the desired input. So those are the physical and morphological parameters of a mesh. What about the material? We have to consider also the material because it will lead the integration of the mesh. And 30 years ago, Grestina described it as a race for the surface. He said that at the end of the day, it will be a race for the surface between cells and bacteria. And of course, you want cells to win the race, because when the mesh is integrated, then it's protected against potential pathogens. So the race for the surface is important and can be impacted by many, many things. And for example, 10 years ago, Dr. Zelzer used a simple experiment. He took a surface, increased the hydrophilicity, hydrophobicity, as you can see on the graph. The more you are on the right part, the more hydrophobic you are. The more you're on the left, the more hydrophilic you are. And in vitro, he put some cells after 0, 1, and 2 days. And what he saw was the more you are hydrophilic, the more you have adhesion and better is the proliferation up to 3 days. So this is theoretical, and what we did in the lab, just to take a look at how is it for real even in vitro, we took 2 meshes which are really nearly identical, really closed. One is made of PET and PLA, 2 polyesters, while the other one is made of a polyolefin, polypropylene, and a polyester, a PLA. And we know that polypropylene is slightly more hydrophobic than polyesters, and we seeded some cells. And what happened after 10 days, as you can see on the left, all the tiny figures you can see on the yarn cells have colonized the entire mesh. While on the right-hand side, cells have first colonized the PLA, which is more hydrophilic, and then they colonize the polypropylene. Of course, polypropylene is a nice material. It will be integrated. It just will illustrate that cells are sensitive to surface, to chemistry, to something like that. It will integrate clinically, but now if we consider highly hydrophobic materials such as EPTFE, fatty acids or something like that, then cells will not integrate the mesh. And then the material will not be protected by the host. So we've got a lot of parameters which can lead to the main integration and success of the mesh, but we also need to consider one specific case, which is what about the placement against the viscera? This is what we call the IPOM, intraperitoneal only mesh, and in that case we need also specific features. Of course, you know, you have a hernia, you open, you place the mesh against the viscera, you close the wound, and then you've got both a biological reaction between the viscera and the mesh with fibrin exudates between the viscera and the mesh, but also a mechanical reaction. Viscera will slip on the mesh and you will have some frictions. And then you will exacerbate the inflammatory reaction linked to that. And those fibrin exudates will become fibrous adhesion during the remodeling phase, second phase of inflammatory reaction. And to avoid that, we can place a barrier between the mesh and the viscera so they can slip at the same time that they are integrated. And this is what we have on the slide. You have dual-sided meshes concept. You can have a barrier which can be permanent or resorbable on one side and a mesh to integrate against the abdominal wall on the other side. And if you look on the right-hand side, what is important to know is the mesh will be integrated by the abdominal wall, and simultaneously the neoperitoneum will climb onto the barrier in order to colonize the barrier. And at the end of the day, you don't need the barrier anymore, so the barrier can be resolved. You will have a neoperitoneum, and everything should go well. It has to be simultaneous. If not, you will have an exacerbated inflammatory reaction, and you may miss the mark. So we want to prevent visceral attachment, but we want to promote cellular attachment on the barrier. All in all, we have to remember that one cannot fit all. The mesh success depends on many, many parameters. I've just quoted some of them, but we've got other. But in any time, the macro porosity should always be over than 1 millimeter, and weight and porosity are two different things which have to be considered differently. And when you are in contact with the viscera, you prefer a smooth resorbable barrier for best integration. And remember, it's always a trade-off between what is my performance, what will be my host reaction, and also what is the user and the procedure. Because sometimes, if you want to do lap or open, you have some specific features that you need to walk through. And this equilibrium may change in the near future with new tendencies, with robotics, with maybe tissue engineering. It may shift a little bit, this equilibrium. So thank you for having listened to me. I'll answer to some questions during the next panel discussion. Thank you.
So first of all, it's a real pleasure for me to introduce our panel. I think as you will see, this is a very diverse panel from multiple different practice types, multiple different countries, and a lot of unique perspectives on how to take care of hernia disease. So I think you'll enjoy hearing from each one of them. We'll start off with Dr. Clayton Petro, who is one of my partners, is an assistant professor of surgery at Lerner College of Medicine at the Cleveland Clinic main campus. Micki Reinhorn, who could not be on the panel session today, but I would really encourage you to listen to his talk about tissue-based repair, because I think there's a lot of great information. And he is a private practice surgeon affiliated with Massachusetts General Hospital and Newton Wellesley in Boston, Massachusetts. Rana Higgins is an associate professor of surgery at the Medical College of Wisconsin. Thue Bisgaard is a professor of surgery in Denmark at Zealand University, and I think has some great perspectives about what matter to patients. Arielle Perez is an assistant professor of surgery at UNC in North Carolina. Michael Liang is a professor of surgery at University of Houston, and Olivier Lefranc comes from Medtronic, is going to speak to us today from a research and development perspective about mesh, and has some kind of interesting thoughts on what are some of the key components. So just for the sake of time, let's go ahead and dive right in there. We're going to start off with Clayton Petro, and Clayton talked about really some of the things that we can do preoperatively to prevent a routine case from becoming a complicated case. And I think as Clayton mentioned in his talk, probably one of the things that has changed and has become the most controversial is our approach to patients who are smoking. And I think anytime you stand up and you say something that is in the face of 50 pounds of printed up literature saying that smoking is bad, you kind of have to take a pause and really dig into the weeds of what exactly do you mean, and tell me, in your clinic today, who are you going to see that you will operate on who's smoking, and who will you still say no to who is actively smoking?
Yeah, so the literature I mentioned, I think it's really important to hone in on what were the inclusion criteria of those cases that we propensity matched smokers and non-smokers. And I think I emphasized this in the talk, but it's worth underscoring it again, that those were clean cases. They were open elective repairs. And so, oftentimes what it's easy to do is look at that and have the takeaway be that, oh, okay, it's okay to let people continue to smoke through the repair, and you start to broaden those inclusion criteria. And, for instance, if I see a peristomal hernia, I should remember that didn't really fit the inclusion criteria that was about. Contaminated cases are still a big no. If I'm doing any redo retromuscular repair, those cases are a little bit more complex and weren't really represented in that cohort. So again, the redo retromuscular repairs are probably not going to be involved. Anyone that I'm particularly worried about, having to raise skin flaps, which we don't do too often, but if I'm worried about skin flaps and blood supply to the soft tissue, I'm going to be a little more careful in that. And then, certainly, these aren't hard and fast rules, but if I'm also looking at someone who's on the upper end of the limit of their BMI, of what we would allow, and the upper end of, perhaps an A1C that I would allow. But if I'm looking at all three together, I might make a judgment call that this is someone that I'm going to push a little harder to get them to quit. Certainly, there's a lot of health benefits to stop smoking. It's not just about wound morbidity, but I think, at least in that specific scenario, I think that, there is some room for flexibility.
Well, let me expand this out to the panel. So let me get real specific and see kind of how you all would approach this. So let's say we have a 9 centimeter incisional hernia and a BMI of 27 after a colon operation. No other major comorbidities, smoking a pack a day. Would anybody cancel the case if that person showed up that day after you had counseled them to quit and they were still smoking? Mike, what do you think?
So I probably realistically would not have booked the patient if they were still smoking. I do generally agree in real practice. Had you made this an umbilical hernia, normal BMI, I probably would have booked it and done the case without much further ado.
So your cutoff is if it's an incisional kind of.
It's a big
After the
decider.
most- Okay.
Yeah, the recurrence rate is so substantially different between the two.
Okay. Thue, what do you think?
Well, we would certainly, we will not actually operate any ventral hernias unless they stop smoking for 3 months. But because we have data, even in the small umbilical hernia data with a mesh, that the outcome will be worse if you smoke. In terms of surgical site infection and recurrence, we have data extracted from the Danish hernia database, which is not published, specifically addressing even the small umbilical and epigastric hernia repair, which was quite surprising for us. Yeah.
Well, let me just push back for a second, because I think this is one of the nice things in Clayton's talk is, what is that data? Because one of the things that surprised us when we looked at this was when you look at these large registries, the actual difference in effect can be quite small and the odds ratios can be quite significant. And I think this to me was very eye-opening. And I mean, honestly, it's hard for me to say that I will operate on a smoker sometimes, because that's very much against everything I've ever believed. But when we actually looked at the effect of it, and in all fairness, I mean, I think this is not a small thing, because when you refuse these people surgery, some of them will come in with an emergency situation and get surgery in the middle of the night. So what really is the difference? I mean, is it a 1 to 2% difference in wound morbidity with a significant odds ratio because you went from 5 to 4%, or like, what is the real difference?
Are you asking me?
Yeah, in the Danish registry.
I think it's ranging from about 5 to 8-9%. So, and a lot of people get these small operations, and we wouldn't put ourselves for doing a bad job, and especially also the patients. And well, that's about it.
Well, just so
addressing the risk of having an emergency operations, nobody has the exact number for the risk in the background population. Actually, we don't know the risk of having an emergency repair. What we have demonstrated early on in the JACs was that the risk of having an emergency repair was very low, but we could see that if you had a large umbilical hernia, for instance, the risk was higher than having a small umbilical hernia. But the opposite was that if you had an incisional hernia repair with a small defect, the risk was higher. So it might be a statistical failure type 2. I don't know, but we found that from, I think it was 3,500 of patients in the JACs some years ago. So the risk is not known.
Let me just to, for the sake of time, one other kind of controversial thing on preoperative optimization is obesity. And I think we all accept that if we could operate on thin patients, that would be ideal. But kind of managing these people is difficult. So I'm going to ask Clayton specifically. I have a broader question for the audience. You didn't really talk about it with Clayton in your talk, but what about the utilization of bariatric surgery in these patients? Is that a reasonable option? How successful are you in doing that? And what is kind of your evaluation of that?
So I don't personally do bariatric surgery, but I'm fortunate enough to work here where there are really skilled bariatric surgeons who I've been shocked in the past that they can sneak in and maybe not do a bypass, but they can do a sleeve preoperatively. And so I think when you have particularly, young patients with a lot of comorbidities who are really, really struggling with the weight loss, and you just don't see a practical way forward for them. I mean, some patients will show up and they will lose a tremendous amount of weight, but if you get the sense in 2 or 3 visits, and again, one of the big things I pointed out was I see these people every 3 months just to check in. I don't tell them to lose a bunch of weight and come back. So if I feel like they are putting in the effort and they do keep coming back and they want to try something else and they have some of the indications for perhaps a sleeve, I'm fortunate enough to work somewhere where they can often kind of sneak in around the hernia and they're able to do a sleeve. And I do think that can be, a huge advantage when you have folks that are able to do it. And certainly those patients will lose a lot of weight. So if they check all those boxes, then I think it's worth it.
Mike, I know you've done a lot of work around this space too, both in trying to kind of figure out cutoffs and then in trials about what happens when you do and do not operate. So just curious now about your kind of steady state of where are you at? Do you have a soft cutoff that you use? Is it just based on some weight loss effort like versus approach? How do you manage the obese patient in your practice?
Yeah, so certainly for incisional hernias, I typically won't operate on anybody over a BMI of 40. I think the outcomes are already poor enough. And then as much as possible, if it can be done minimally invasive, the open rates of wound complications are tremendously high. And then final thing that I've not really talked about, but I take more into consideration are the characteristics of the hernia. If there are increased risk for incarceration, or if they've had multiple visits to the emergency room already, those things will shift or mold my opinion. But in general, for the small primary ventral hernia, I might be more lax on some of the standard criteria. And then the larger and more complex the hernia, I tend to be more strict on the criteria because the outcomes, the margins for good outcomes are so slim.
Rana, I know you guys kind of intermingle with a lot of I can't remember if you do bariatric surgery yourself or not, but
yeah,
you do?
I do.
So how do you manage it as a bariatric surgeon in kind of doing both?
Yeah, so if I, and this has happened many times, but if I see a patient, my hard cutoff is a BMI over 50, then absolutely, just as Mike was saying, no opportunity for an open incisional hernia repair, then I'll offer them a sleeve. And really be realistic about the timeline, because here in the United States, the timeline to get bariatric surgery can be anywhere from 6 to 9 months. So having them undergo the sleeve and then waiting about 12 to 18 months until their weight has stabilized until I do the open kind of component separation. If they're between BMI 40 to 50, as he said, I agree. If you can do it minimally invasive, then I would do it that way. Unfortunately, I'm here in Wisconsin and we have probably the worst bariatric surgery coverage in the US. So that is one challenge we have, but definitely I've had many hernia patients where I kind of steer the conversation away from the hernia and more toward bariatric surgery for that reason. And I talk a lot about the outcomes, recurrence rates, things like that.
Okay, so let's change gears for a minute so we can get through to everybody here. And Micki Reinhorn could not be here today, but I would encourage everybody to watch his talk because it talks about tissue-based repairs. And in full disclosure, I spent a day there learning how to do a Shouldice repair about a month ago. So I do have some kind of intimate knowledge about what he does. So with that bias, I'm going to be open about it. I'm just curious for the panel, raise your hand if you offer a BMI of 22 in a patient who does not want mesh. It's not uncommon today in a male, no prior surgical history. How many of you would offer him a tissue-based repair? Okay.
So it's not really an issue of offering. The patients already said they don't want mesh. It's either operate or don't operate.
Well, so let me push back on that for a second, Mike, and ask. So, because this is kind of what we're running into now, which is why I, quite frankly, went out there to learn, is I don't really have a great tissue-based repair to offer the patient because I trained in the era of laparoscopy and we just didn't do it. And this is becoming a much more common question. So it kind of leads, I'm going to ask a philosophical question, and everybody kind of feel free to join in. And I think Micki makes a really good point about this, which is, particularly in the United States, it's a small group of patients, but these are people that are candidates for tissue-based repair, which are reasonably healthy, thin, BMI, I think his cutoff was less than 25, and are willing to have a little bit more discomfort up front. So with that caveat, in those patients, and in women, I think was his other big group that he does it in, are we using too much mesh in these thin, healthy patients with inguinal hernias, understanding the complexities of chronic groin pain? And we'll get to 2A's kind of concerns about what patients feel like matters. Have we swung way too far? So what do you think? Let's start with you, Mike, since you're...
I don't. I think the evidence strongly supports it. I really think the question more is from our perspective. People here at our institution are barely even doing open repairs. Everybody's getting minimally invasive repairs, which for the most part require a mesh placement. So, and then there's also pretty reasonable evidence of systematic review of randomized trials that show that mesh doesn't necessarily cause more chronic pain. So combined with minimally invasive approach, which that pendulum might have swung too far, with the decreased chronic pain, mesh is still my go-to. I will do a suture repair for a patient who absolutely refuses mesh only after I've counseled them on the benefits.
And what type of repair do you do?
I would do an open Shouldice repair. I think it would be interesting. I'm surprised we haven't talked about, or is anybody doing a robotic Shouldice? Because many of us are doing robotic Bassinis.
Wait, okay. 2A, well, how about Denmark? How do you guys handle this? I mean, obviously you guys have a very strong registry. You know your long-term outcomes. And I mean, and honestly, in general, you have a thinner patient population than we tend to have in the US, although that's probably shifting. What is the use of tissue-based repairs there?
Well, two things about that. I would do a lousy job if I had to do a Shouldice. It's almost 10 years ago, and I was trained to do it many years ago, but I would certainly refer that kind of repair to another guy who was much more trained in that. But a specific group of patients which may benefit from a non-mesh repair is, well, we're studying this in a big PhD study, and that is the Crohn patients, the IBD patients, which may be, at least in those with the fistulating Crohn, they may be the specific ones which we may gain from a non-mesh repair. But of course, in the US, where you have this big litigation issue, there may be some patients, but I think in Denmark, we do less than 50 in our population of 5 million. And most patients, I think it's 80% in the Danish population, which is having, by tradition, a TAP repair. We don't do TEP because TEP or TAP, that doesn't really matter. But the question was a different one you posed, Mike.
Arielle, any thoughts about would you ever use a tissue repair? I didn't teach you how to do that. So but did anybody?
No, so actually, I did like 1 or 2 Shouldice repairs during residency, but I feel like in my hands, the best repair is going to be either a minimally invasive repair or an open Lichtenstein repair. So usually I'll go over it with patients and tell them my data, tell them if they are really seeking out a tissue-based repair, I'm more than happy to try and get them a referral into the best hands. And I think, you know, in terms of evidence, it really is the high volume centers. And I actually have referred maybe about 2 or 3 patients up to Shouldice Clinic, where patients have actually asked me to send their charts up to Toronto. So that's what I end up doing.
Let me get a little bit deeper on that with you. So, and we'll get to your talk about umbilical hernias, but in the general sense, if I understood your algorithm correct about umbilical hernias, if we could apply that to inguinal hernias, the general concept of umbilical hernias would be, if it's small and fairly routine, a primary repair works the vast majority of times and save mesh for the failures. Is like the less than 1 centimeter hernia, I think that was kind of the general theme. So if that's the case, why isn't that okay for an inguinal hernia? Where obviously for a large hernia, obese. So why is it that as a young surgeon like yourself, you're not, you know what, I need to learn how to do it? Because I would not, I think like everything in hernia surgery, pendulum swings so far, all we learn is how to do mesh. But why not for the small ones? And even if you look at the large trials, the recurrence rates are 10% at most, which means that 90% of the time it worked without mesh. So why doesn't that apply? What you said about umbilicals not apply for the small routine inguinals?
I think just anatomically for an inguinal, there's a lot more risk in terms of chronic pain with the nerves. In terms of the dissection for a tissue-based repair for an open inguinal, you're going to be going through many more tissue planes than you would be just for a primary open umbilical. So you're creating a lot more scar tissue, creating a lot more difficulty for the potential future need for a recurrent repair. And then also you're putting a lot of nerves at risk. So you're increasing the risk of pain.
All right, Rana, I'm going to get to you now on this. So we just agreed that most of us on this panel who are expert hernia surgeons find it overwhelmingly complex to do a tissue-based repair and send our patients to Toronto to do that. So help me get to the point where with that as the kind of base, we're now going to be doing advanced MIS repairs in the retroperitoneum to fix these hernias, and the outcomes will be better. So my specific question to you is, what does it take? What did it take you in your practice to become where you felt like you were proficient in laparoscopic inguinal hernias? Let me just start with that.
Yeah, I think there's lots of literature to show this as well, but the learning curve for a laparoscopic inguinal hernia is much more significant. I think, a lot of it depends on your training. I didn't have any experience with laparoscopy in terms of inguinal hernia repairs when I was a resident, so I learned all of that in fellowship. We did a TEP approach. Some people learn a TAP approach. So I think comfort level with the retroperitoneal anatomy and the preperitoneal anatomy is the key to the learning curve for feeling comfortable with the laparoscopic inguinal hernia repair. But the big study from the early 2000s in the New England Journal of Medicine said that learning curve can be as high as 250 cases. So I think it depends on exposure, what your training is and all of that, but it's quite a steep learning curve for laparoscopy.
Okay, so with that kind of answer, that the fundamental struggle is the anatomy. And then how do we get to the fact that the robot enables surgeons to do an operation that makes the anatomy more clear?
Yeah, I mean, I find that to be interesting as well, because the anatomy is the same, visualization that you get for laparoscopy. I do think that you get a wider field of view with robotics. I think the 3-dimensional visualization does help in terms of identifying important vascular or neurovascular structures more so than laparoscopy, and more range of motion with your hands. So I think that that can make a more complicated or confusing anatomy in the preperitoneal space perhaps a bit easier for people in their learning curve. Again, it's hard to say, but the data shows that the learning curve for robotic inguinals is less than laparoscopy. And I think a lot of that has to do with instrumentation and visualization.
And so just in your practice every day today, how do you decide? Because obviously you can do an opening. I'm assuming you do a Lichtenstein if you do it open. Is that?
Yeah, like Arielle. Yep, I would do a Lichtenstein if I do it open.
So like, take me through, how do you choose in your practice between being proficient at all three? How do you choose who gets what?
So I typically, from a minimally invasive approach, I always offer the robotic approach. And that is pretty much standard in all of my inguinal hernia patients. I offer open repairs for elderly patients, so those over 80, those who are on therapeutic anticoagulation, those who've had any significant abdominal surgery where going in through a TAP approach wouldn't be as safe due to the adhesions, or if it's an incarcerated inguinoscrotal hernia. But otherwise, everyone gets offered a robotic repair. I don't actually do many laparoscopic repairs anymore.
Okay. And Mike, I think during your talk, you talked a little about that. Let's stick with the inguinals for a minute. It sounded like at your place, if I understood you correctly, the vast majority of at least MIS inguinals are now performed on the robot. Is that true?
It is true. In fact, so as you know, I transitioned from UT to University of Houston, and here almost all of the cases are done, inguinals are done robotically. I would say anecdotally, half of my PGY 2s and 3s can complete a robotic inguinal hernia repair, whereas for laparoscopic inguinal hernia repair, probably less than half of the PGY 5s could complete it. There is something technically and visually easier for the inguinal hernia repair to have a lower learning curve, it appears.
So I have two big questions about it. And to me, this is kind of, we'll talk about this when we talk about robotic ventral hernias with you, but I think to all of you, but to Rana and Mike in particular, if I understood your talks correctly, and basically what you guys both just said, is something that the robot is doing is it's taking somebody that cannot do an operation well, whether it's lap or open or whatever, and allowing them to do the operation. So my big question is, one, how do we know that they're just not sitting there comfortably with three-dimensional view doing the same bad operation, but just feeling better about it? Number one. And number two is, to me, that's the next frontier of robotic surgery, is establishing with data. Does it actually do that? Does it take novices and make them more experienced? And so kind of what is the path? And Rana, let's start with you. What do you think is the way to do that? Because I think we need to provide some evidence to support this concept, because it's a recurring theme. And my last comment about, I think most of the data shows, and all the randomized controlled trials done by experts, if you're good at an operation, you get the same results no matter what you do. So that kind of has been beaten to death. The question is, what about the less experienced people?
Yeah, and I mean, especially talking to residents, because I do run the resident robotic curriculum. I mean, we have a procedure simulation on the robotic simulator for inguinal hernias. So I think that alone helps quite a bit, because there's an anatomic identification, there's a free-handed and a guided dissection. So just as Mike said, you can have PGY 2 and 3 residents who are more comfortable with the anatomy. We personally here don't have a comparable simulation for laparoscopy. So I think there's more opportunities for simulation for novices, especially for inguinal hernias, where they can feel comfortable. And I think that exactly what you were saying, that's a little bit of an intangible that we don't understand yet. Is it the visualization? Is it the ergonomics? Is it the wristed motion? What is it that's making this learning curve different? And is it actually different? That's the part I think that is still a little bit unclear to everyone. But from a resident standpoint, you can definitely train them better, I think, from an inguinal hernia standpoint.
Mike, do you think there's a way to study this? I mean, obviously you've done a lot of clinical trials. So what is your, do you have anything cooking you want to share with us, or any ideas on how to actually start addressing some of these questions about, how to put some science behind some of these feelings?
Yeah, so I actually would throw this into you and Thue's court. I would guess the best way to study this would be a multi-center randomized trial, similar to the learning hours in residence. So some centers, the residents start off just doing robotic inguinal or robotic chole, and then others just lap chole, lap and lap inguinal. And I agree with everything that was said, which is watching a resident do a laparoscopic peritoneal flap closure is very hit or miss. Watching them do a robotic peritoneal closure is very easy. There's some combination of it for the inguinal hernia. Now, if we're talking about an IPOM ventral hernia, I didn't find that the residents were particularly better or faster at sewing a circumferential 20 by 25 piece of mesh. That was a very difficult procedure for them to do. But a peritoneal flap where the ports are triangulated and 20 centimeters away, that's like a chip shot for them.
Okay, let's move on to 2A. I found your talks to be very fascinating because it kind of moves the whole paradigm of hernia surgery away from things that are kind of surgeon focused, which we always like to focus on, to patient focused, which is a big kind of movement. So I have two main questions for you is, with all of your passion about this and with the kind of registry and Danish hernia registry, how did you guys incorporate patient reported outcomes into the day-to-day care of patients and decisions that you make? Has that happened yet? Do you have a plan to do that?
Well, this is about the PROMs, I guess, for the patients. And we are now building a local database, which we will try to get into collaboration with perhaps some of you guys. And we have planned, and we are very far with this. We have planned a protocol, so to speak, where patients fill out, of course, standardized PRO data questionnaires. PRO data is a parallel umbrella of quality of life, and you all know that, and PROMs is isolated symptoms. So we have put a standard battery, so to speak, and what is very important that we ask the patients before speaking to a surgeon about these standard questions and questionnaires, and we follow up with the questionnaires 3 months, 1 year, 3 years after the operation. And of course, the questionnaire will some kind differ if you have just small operation like inguinal hernia and a peristomal hernia, because they have different symptoms. And we try to incorporate what is called MyMap, measure yourself medical outcome profile. So we know from the literature, and Mike, you've been involved in a recent publication on that. No studies have tried to use patient outcome, where the outcomes has actually been defined by the patients, and not by the surgeons. And I'm not sure that all these PROMs used in the many studies are actually valid, because no one has asked the patients, what do you think? What you might feel is your problem, Mike, before undergoing, let's say, incisional hernia repair, God forbid it. But your problems may be different than my problems. I may have difficulties in biking. You may have big problems when you're sleeping on, in the back and so forth. So I think that's a major issue for future studies.
Let me add on to that, because I think, and this is going to lead me into a discussion with Arielle about umbilical hernias. And in a broader text, when you look at your work in this, and when you kind of set the stage that I think we all agree that emergency surgery related to most hernias is rare, but a real number. So the vast majority of what we're doing every day is quality of life surgery, which is incredibly important. But if you accept that we're doing quality of life surgery, and then you look at the fact that the vast majority of, patient reported, although not with MIMOS, but with patient reported outcomes, don't show huge benefits in the vast majority of hernias that we're fixing, it calls into question, why are we doing this at all? And should we take a step back and have much more watchful waiting type studies to see if there really is no difference? And if the crossover rate isn't unacceptable, what do we do? So I'm going to ask you the question of, knowing what you know now, when do you operate on these small hernias? And I'm going to ask Arielle as well to defend kind of her entire algorithm, which was fairly surgical early, and somebody comes in your office. So Thue, like, knowing what you know now, what are the hernias based on all the information you know about quality of life? How we're measuring it hasn't changed that much yet. Has that guided your operative indications?
Well, I have a problem, and the problem is the literature. In that area, I think the literature is too bad, actually. The bad quality of many studies, as we reviewed in this recent systematic review, there were, I think it was 21 studies which qualified from, which was included in this systematic review, was more or less poor, the quality, or moderate. Only one study qualified as a good study. And I think it's not a question of improving quality of life. I think it does in many patients, the majority, but the literature is too poor to demonstrate it. So it's all over again.
So just to follow up to that, have you looked at any decision regret scales at all? Because this is an interesting avenue in my opinion, an untapped resource in surgery, which is at the end of the day, no matter what the outcome, if the patient regrets it, we probably shouldn't have done it. And if they don't regret it, even if they have a recurrence or whatnot, are we still helping them? Any thoughts on that?
Yeah. Am I the one to answer again?
Yep.
Sorry if I bore you, but we know, at least the literature, also stressed by Mike's early recent study in the surgery, we know that oligosymptomatic patients are not doing that well after surgery as the symptomatic ones, the very symptomatic ones. That's the point. And the question is, if you have a giant hernia repair and the patients were in the very bad shape postoperative, and when he heals, he might have, well, he had a very bad quality before this surgery, and but after a year, he may complain and have major complaints about the scars, even though he was he was in a bad shape before the operation. So if you ask about discomfort or any kind of PROMs, it may be improved, but de novo symptoms may be something completely different. And I've seen some patients complaining of the scars, that it was ugly and stuff like that, although the pre-op poor quality of life was improved post-operative, but he then has some de novo symptoms. So
So Arielle, let's move on to umbilical hernias. And I want to, for all the viewers, please watch Arielle's talk, because I think she really does a phenomenal job. Number one, showing the complexity in decision making for umbilical hernias, because I think we could all agree should be a relatively routine hernia. Kind of the process to decide what to do is very in depth, and I think that just shows how far we've come as a field. That, you know, the choice of mesh, no mesh approaches, and all these things, and I think that's a good thing. I don't think complexity is a bad thing. I think accepting it is key. But Arielle, kind of respond to Thue's comments that at least as we've measured it today, we're not really improving people's quality of life that much with umbilical hernias. So should we be doing this at all?
So, it comes down to really having a good discussion with your patient, I think. Really setting their expectations about what they would like to accomplish and what you're going to be able to accomplish for them. If a patient's coming in because they have a cosmetic issue, because they don't like the bulge around their belly button, you can say, I might be able to improve it, but I can't guarantee it's going to be something that's completely satisfactory to you. By fixing a hernia, your main goal is really to reduce the chance of having the life-threatening issues of incarceration, obstruction, and strangulation, as well as hopefully being able to help them improve their core muscle strength and increase their ability to kind of do other things during the daytime and whatever type of activities they want to be able to do. But the main thing with the hernia repair is truly to close the hole and take care of the issues with getting bowels stuck through the hole. And so being able to set those expectations with the patients, I think then kind of drives what they want to accomplish with surgery.
Okay, let me ask you about a specific group, because it seems to be a daily occurrence for us, and certainly challenging, is cirrhotics with umbilical hernias. So obviously this is the highest risk group of patients to have complications. So just curious about your decision between primary repair versus mesh in a cirrhotic, particularly somebody, a true cirrhotic with ascites, not an emergent repair, but an elective patient with ascites and 1 centimeter umbilical hernia. Do you use mesh in those people? Do you close it up primarily and hope to get them to a transplant? What's your feeling on that?
Yeah, so cirrhotic patients, if we can get their ascites as best controlled as possible, so working with the hepatologist, working with the transplant team, do they need a TIPS? Because if they're just continuously developing ascites, even after paracenteses, I'll tell them, there's no reason to get this fixed. You're going to continue to develop the ascites. The hernia repair is not going to last, whether I use mesh or whether it's just a primary repair. If we can get them fully optimized from their cirrhosis standpoint, 1 centimeter defect, number one, I'm going to get a CT scan with IV contrast, double check, make sure that there's not just some sort of large varice that they're noticing going out through that hole. Because if that's truly what's going through, I'm not going to repair it at all. If it's just a little bit of preperitoneal fat and it's causing some pain and discomfort, I'll have a talk and a discussion with them. It's going to be an open repair. And depending on really the size of the defect, once we actually get down and I'm able to see the fascial kind of ring of the defect, if I can put mesh in without having to increase the size of the defect to get mesh underneath in a preperitoneal spot, I'll do it. But if I have difficulty being able to put mesh through the defect because it's so small, then I'll just close it primarily.
Okay, so just for the sake of time, I want to jump forward to Mike. Mike, another great talk, and obviously, you've completed one of the largest randomized controlled trials about robotic IPOM versus lap IPOM. So I'm just curious, today in your practice, what is the role for robotic IPOM and what is the role for laparoscopic IPOM on your day-to-day management of patients?
Yeah, that's a great question. There's a lot of factors that go into it. In general, there's no clear clinical benefit for robotic IPOM versus lap IPOM, and it takes longer. And on a case-by-case basis, there's an increase in healthcare costs. So I don't routinely utilize robotic IPOM for ventral hernia repairs. The times that I will use robotic surgery for ventral hernia repair includes somebody who does not want tacks or additional foreign material, that suturing is a preference to them. Somebody that might benefit from a preperitoneal or retromuscular repair and a minimally invasive repair in combination. But in general, my go-to for most hernias is still going to be a laparoscopic ventral hernia repair.
And so let's just dig a little deeper on the RTAP. I think you mentioned that in your talk. So, because that's an operation, honestly, that like really confuses me, particularly for the umbilical ones. And again, not having done them and not being really a heavy user of the robot, particularly with ETAP available, it seems like a pretty tedious dissection with a lot of risk of peritoneal breakdown and whatnot. So you did mention it. So could you just expand for a minute on, what are the actual cases you do RTAPs on, maybe over an ETAP or a Reeve-Stopa type approach?
Sure. So that's a great question. And I know you and I have talked a lot because early on, when you were finishing your fellowship and we had talked about preperitoneal open repairs, like how tough it is to develop that preperitoneal space in the central abdomen. So as you guys all know, there's this large fatty strip that comes down from the falciform and goes through the umbilicus all the way down to the bladder. So you have maybe a 3 centimeter margin where it's pretty reasonable to get a preperitoneal space. And then just beyond that small strip down the midline, it's extremely difficult to develop that preperitoneal space. So what we actually do is, if I'm going to truly go with a pure preperitoneal, I'll take 60 cc's of saline and inject it in the preperitoneal space on either side of that landing zone so that I can create a wide 6 centimeter a 5 centimeter peritoneal space, because in my hands, I can't reliably create a preperitoneal space robotically or open in that situation without that extra assist. So I'll go ahead and make that, and then I'll dissect out 5 centimeters from the fascial defects, utilizing that saline created space to get into the true preperitoneal space. Why is the ETAP problem? I think the ETAP is a misnomer because it's really, you're violating the retromuscular space. And I feel, I don't have evidence to support this, I feel like there's something wrong with violating the retromuscular space for an umbilical hernia repair. I feel like this is a golden space that should be saved for your more complex cases. And I personally, you will have to twist my arm and provide multiple randomized trials to justify violating the retromuscular space for a simple hernia repair. Excuse me, for a primary ventral hernia repair.
I think that's a great point. I think, I think one of the things about hernia surgery is, from a technical aspect, things really take off because they look cool and they're fun to do, and often don't think about the consequences of being in that space. And I think that, I couldn't agree with you more that the reality is the fact that we're using some of our biggest guns to approach something that probably just needs a sniper, it is going to have a predictable rate, although we don't know what that rate is, of regrettable consequences. So just thank you very much. So to wrap up, Oliver, I wanted to bring you in as well, because again, another great lecture, and a lot of us don't like to think a lot about the mesh we use other than the size, but there's a lot of science and thought that goes into the different products. And so just a couple of questions for Oliver. I think one of the things that you showed and spoke a lot about were kind of those pictures of bridging fibrosis, and kind of from an animal and a theoretical model of healing about why when those nodes are too close, there's this so-called bridging fibrosis. So you may or may not know this, but let me just ask you, outside of the modeling aspect of this from a kind of wound healing and animal studies, in vivo studies, clinical trials, really, we haven't seen that to hold true, that there is clinical evidence that a heavier weight or potentially even microporous causes this so-called bridging fibrosis to where patients complain of it. So I'm just curious if you have any feelings about kind of transitioning that leap between the theoretical aspects, because we have really got down this path of macroporous, kind of medium weight, and although they're not exactly synonymous, and you bring up that point well, for all intents and purposes, they can be lumped close. What do you think about the absence of clinical findings that really support most of this research?
I think that if we take a look at all the data and all the things like that, we also have to think that a lot of patients who have a hernia also have metabolic disease or something which does not go right. I don't speak about sportsmen who can do a hernia because they force too much. So, and we know it has been described that shrinkages, mesh traumas was, for example, mentioned by some Netherlands surgeons can happen. Or, of course, we have the theoretical aspect, but also quite a lot of literature that show that some shrinkage can happen. And as you said, some of the shrinkage may not cause alarmous or strong disease, which may require reoperation. But as you mentioned, some of the patients said they regretted some of the hernias. Could it be linked to some pain, residual pain? And it's one of the problems that we've got with the permanent device. The mesh is here forever. So the only way to know how it goes is for a second look, or after when you just have to extract the mesh, or if the patient does not complain. So we've got the theoretical model, we've got literature data which says that some shrinkage can happen and usually is linked to some specific part of the devices. And we have to try to align with this theory in order to avoid any strong adverse effect or thing like that. We have to stick with something we know.
And then my last question for the whole panel session will be for you, Oliver, in that, you know, one of the things that we're seeing more and more of for all different types of meshes, some more than others, and a lot of this has been this push to kind of decrease the weight, increase the pore size, is mesh fracturing. And I think probably everybody in the panel has seen this happen to some extent. In what extent, I think it's going to require a large registry to really kind of figure this stuff out. But these can be quite devastating. So I'm just curious from a mesh design perspective, you know, how serious do you think long-term fracturing of the mesh is? And do you think there's some sweet spot that we can get to where we have the right weight and the right porosity, where it works from a healing perspective and doesn't break later on?
So it's not only a question of weight and porosity, it's also a question of elastic properties, how it fits to the abdominal wall. Something which is really, very important, I think, to mention is the mesh is not here to replace abdominal wall. It's here to reinforce. It means that it has to be integrated into the tissue in order to reinforce the abdominal wall. If something goes wrong with the tissues itself, the mesh won't work by itself to reinforce and may lead on a longer time on fracture. So it's a global aspect. So the meshes are tested in many, many ways. We know that we take into account anisotropy, we take into account the maximum force. Something which we are working on now is to better understand the needs of the abdominal wall with finite element analysis, with fine analysis of the main need in order to adapt as much as we can. But if the mesh does not integrate, if you don't close the defect, for example, if you have a big hole with the mesh which is not kept into the tissues, it cannot last forever.
All right, well, on that, I want to, we'll wrap this up. I want to thank all of our panel members and speakers. I think not only were your lectures fantastic, but I think this was a great, rich discussion. And I think like all great discussions, they often leave with more questions than answers. And I look forward to the session live when we get to do this. But I just want to thank each of you for taking the time and effort to do this, and to Advances in Surgery and Dr. Wexner for putting this on. So thank you all. Everybody have a great day. And this will wrap up our panel session.
We are constantly improving our surgical training. This is why we need you to participate in our AIS core initiative to rate the quality of our content. You can rate our content by giving it a score from 0 to 10. 0 meaning not useful and 10 meaning extremely useful. You can tell us if this is a good content to share. Thank you for your commitment to the democratization of surgical training.